Hello. I am Clinical Director of Alta Mira Recovery Programs. My name is Dr. William Hanna. And before I start talking about the personality disorders, I would first like to take this opportunity to inform you that there are many exciting and innovative programming currently happening at Alta Mira. We provide an enhanced brain-healthy curriculum within our Monday through Sunday 35-day core program, which includes educational, didactic lectures and related integration of knowledge and skills within the interactive practical groups which happen in the afternoon. In addition, we employ a philosophy of treating addiction through biological, psychological, social, and integration means of modalities. What I believe truly sets Alta Mira apart from other substance dependence treatment facilities is our highly credentialed professional team, including 7 doctoral level clinicians on staff, our state-of-the-art neuropsychological and psychological testing with Dr. Patti Weiss, including assessment and diagnosis, and providing 3 individual therapy sessions to each client per week. Also, our cutting-edge brain-healthy curriculum and the ability to provide brain SPECT scans or images. I am most proud to report witnessing our medical department, nursing staff, primary therapists, program assistants, program counselors going above and beyond in their commitment to offer a higher level of care. Furthermore, in our commitment to working with referral sources, we believe success requires teamwork, communication, and collaboration among all stakeholders. So I wanted to say I'm honored and happy to be here today as your speaker. It's nice to see so many familiar faces and also some new ones as well. For as long as I can remember, I've had a special interest in personality development and personality disorders that can explain the way people function and relate. There are 2 kinds of people in the world, those that are emotional and those that are intellectual. A healthy individual has a good balance between emotional and intellectual. I'm going to give you a little bit of self-disclosure right now. I grew up in a family with a very narcissistic father who is also an alcoholic and a rageaholic and also a workaholic. My mother is a dependent personality type, and because my family lacked boundaries and were psychically intrusive, I closed down emotionally in order to get away. As a child, I felt intruded upon and my privacy was stolen. My strategic defense, therefore, became to withdraw and to minimize contact, to simplify my needs, and to do whatever I could to protect the private space within. This paved the way for the structure of my personality, where I live with avoidant traits and have thus become an observer of life. I'm going to shift gears a bit now and move right into the personality disorder lecture. The shaping of one's personality consists of 3 interdependent factors. 1, psychological factors. 2, physiological factors. And 3, environmental or interpersonal factors. Together, these influences will determine the anxieties and need states that will result in the development of specific unconscious defense mechanisms and conscious coping strategies of the person. The key to understanding adult psychopathology lies in an understanding of childhood and adolescent development. Before ethically diagnosing a client with a personality disorder, the client must sit for a battery of psychological tests, such as the MMPI-2 and the MMPI-3 and/or the Rorschach. Here is the definition of a character disorder as viewed in the DSM. A personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. A personality disorder or character disorder is a historical diagnosis. The critical criteria for making the diagnosis lie in the client's history, not in the client's behavior in the interview itself. I can't overemphasize that enough. The client's immediate behavior in the interview often provides important clues to underlying psychopathology, but the criteria for establishing the diagnosis lie in historical evidence. A personality disorder leaves historical tracks. The nature of these tracks varies significantly, and one of two elements will be present. Either the client's rigid defenses results in behaviors which are disturbing to other people, or in feelings which are unsettling to the client. For example, a person with antisocial personality disorder may steal the life savings of an employer who trusted him implicitly. He may have no regrets about such actions, but clearly his behavior will have had a disastrous effect on the employer. Such behaviors are called ego-syntonic because they do not disturb the client himself. At the other extreme, a person with an avoidant personality may shun almost all social contact while living in a self-imposed interpersonal tomb. This behavior may not really harm anyone else per se, but results in significant personal distress. These types of behaviors are referred to as ego-dystonic because they directly create subjective pain in the patient. By the way, I'm going to do questions and answers at the end of the lecture, so we'll make sure there's enough time for that. Some clients show a combination of ego-dystonic and ego-syntonic symptoms. Clients who display mostly ego-syntonic behaviors are not strongly invested in receiving help because their behaviors are not disturbing to them. So they're not motivated to get into treatment. In uncovering personality disturbances, the clinician must actively search for consistent patterns of behavior, demonstrated from adolescent onward without major disruption of these patterns. It's important to recognize that pathology is directly related to lack of self-esteem. It is promoted by a dysfunctional communication system designed to suppress feelings. Virginia Satir was famous for her work on getting people in touch with what they feel and then expressing it. A good example is seen within the film Ordinary People. I guess I'm probably dating myself now. Pathology is not saying or expressing how you feel. I'm going to repeat that because that's so important to internalize. Pathology is not saying or expressing how you feel. The main character in the film had survivor's guilt, a flat affect, and major depression. One would not use a cognitive approach within the Ordinary People film because all of these characters lived in cognition. So that was not going to help move him into a place of emotion. The therapist in this film was most successful in getting the main character to emote and express feelings. That is what that client needed most in order to heal. Great therapeutic progress was made during a catharsis, having an emotional feeling which is expressed. The degree to the exaggeration of expressions of behavior tell us if one has a personality disorder. Emotional health can be directly linked to the degree to which one can tolerate frustration. Axis 2 looks at disorder of character and core problem. Disorder of core is ego-syntonic. The action of the client is in agreement with his or her core value. This is not an avenue that creates stress for the individual. So of course these individuals are harder for us to get into treatment and harder for us to make a difference and get them to progress. Disorder of character is ego-dystonic. A client behaves in a way where he or she is clearly distressed about their behavior. The behavior is incongruent with the client's character. Again, a perfect example for that is someone who has avoidant personality disorder. Someone with avoidant personality disorder wants desperately to get into a relationship, but he or she has too low self-esteem to make that happen. Oftentimes, the avoidant personality disorder will wait for someone to show this person that he or she is interested in him before the avoidant personality disorder can even engage in a relationship. So there is distress and insight there, which is a great thing. To treat ego-syntonics, you must move them to an ego-dystonic place. And again, ego-syntonics are an example of the antisocial personality disorder, where they're not very invested or insightful about their problems or even disturbed about their behavior. So to move someone from ego-syntonics, to do this, you need to build a structure to allow the client to feel distressed. Anytime you're looking at a personality disorder, you need to look at interpersonal relationships. So whenever I'm working with someone who has narcissistic personality disorder, one of the key things that I am aware that I need to do is, because they're so invested in their image of who they present to the world, in order to help them to progress, what I do is I reinforce this person whenever he or she expresses their true self or vulnerability about themselves. Because someone who's narcissistic tends to present strongly more of an image to the world. Anytime you're looking at a personality disorder, you need to look at interpersonal relationships. You want to do a thorough evaluation about their relationships. The DSM arranges the personality disorders in clusters. Cluster A includes individuals that often appear odd or eccentric. and they include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B includes individuals that often appear dramatic, emotional, or erratic, and they include antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. And then cluster C includes individuals that often appear anxious or fearful. They include avoidant personality disorder, dependent personality disorder, and obsessive-compulsive personality disorder, not to be confused with obsessive-compulsive disorder. They're two very different disorders. In fact, I've written several letters to the committee on the DSM to change the title of the obsessive-compulsive personality disorder because it's confusing and it doesn't quite describe clearly enough what this person is all about. And the new DSM is going to be coming out in 2013, and it will be interesting to see what changes have been made. The reason I chose to talk specifically about antisocial personality disorder and obsessive-compulsive personality disorder is because the current DSM does not do justice in fully explaining both of these disorders, antisocial personality as well as obsessive-compulsive personality disorder. The core issue for the antisocial personality disorder is self-hatred and feeling ripped off from birth. A person has to have a history of conduct disorder before age 15 to be diagnosed with antisocial personality disorder. I'm going to start talking a little bit about films in terms of understanding personality disorders, and I studied in my doctorate program both advanced adult psychopathology and then adult psychopathology, learning about adult psychopathology within the medium of film. And my genius of a professor is actually here tonight. His name is Neil Coburn, Dr. Neil Coburn. He's right here. Can you stand up? Yeah. So you've been a huge inspiration. In fact, I'm writing 2 books right now on personality disorder, and I'd be honored if you wrote the foreword to the books. Yeah. The film 6 Degrees of Separation represents classic elements of antisocial personality disorder, where Will Smith plays a character that lies and manipulates society for his own gain. There are 2 kinds of antisocials. This is where the DSM falls short. Okay, you're not going to find a lot of this information in the DSM. 2 kinds of antisocials. One is sociopaths, and these are people who manipulate the law for their own gain, and it usually does not involve violence. The second type would include psychopaths, which is more reflected in a serial killer such as Ted Bundy or Jeffrey Dahmer. Antisocial comes from you owe me and I'm going to take it. This is an attitude and a belief. Antisocials were the children, the infants that were not held. These are the infants that were left alone for hours and days without being touched. Antisocials are created by underreactivity and no response from mom or a caretaker. These are the infants and kids that were left alone, not stimulated by holding or any type of affection. What happens is one's spirit gets broken, which leads to apathy, which leads to you owe me, which leads to I didn't get it, as a child, and I'm going to take whatever I want now. And that's why these people are most often in prison or jails. Our jails and prisons are filled to capacity with antisocial personality disorders. These are the nonconformists from early on in life. The rights of others are of no concern for these people. Words that describe an antisocial include truancy, delinquency, suspension from school, runaways, lying, vandalism, substance abuse, promiscuity or aggressive sexual behavior, cruelty to animals, oppositional behavior, impulsiveness, recklessness, unlawful behavior, absenteeism, aggressiveness, also an inability to maintain satisfactory job performance, a high degree of unemployment with these people, an inability to maintain attachment to a sexual or intimate partner, failure to honor financial obligations. The archetypal is the con man. Another great example of this type of person is in the documentary independent film called Con Man. Has anybody seen that film? Yeah. It's a true story of an Ivy League imposter, and if you haven't seen it, it's one of the best documentaries I've ever seen. It feels like the movie is over in 10 minutes because it's so well made. These individuals with antisocial personality disorder have no conscience. They act in ways that do not create guilt or shame. With antisocials, there is a deficit in the superego, which lets you know you are acting appropriately. Antisocials lack lasting, warm, and responsible relationships. The mafia, their values that they hold are classic antisocial. There's an interesting element about anxiety and antisocials. Antisocials have a unique ability to displace their anxiety onto other people. It is powerful and reassuring for them to make others anxious and reactive. I don't know if anybody saw this, but Charles Manson manipulated Geraldo Rivera in an interview on television, and I'll never forget it. Antisocials feel no guilt or remorse, and they do not learn from punishment or consequences. They're a huge challenge for clinicians to work with. Of all the personality disorders, they are the least curable. The only effective treatment for antisocial personality disorder appears to be the passage of time, where the individual becomes less impulsive and less predatory. Antisocials have a very low frustration tolerance, which leads them to impulsivity in using drugs and alcohol. They are predisposed to conduct disorder, attention deficit disorder, extremely low self-esteem, and internally they feel inferior. But they don't put that out to the world, but internally that's how they feel. There's a high correlation with adoption and antisocials. A conduct disorder child comes from parents who don't care, inconsistencies in parenting and hostility. Apathy in the child leads to anger. If a baby cries and there is no response from a caretaker, the baby eventually stops crying. The baby develops no trust. The apathetic response turns to anger, and it eventually becomes "I'll get even." A key need is feeling loved, recognized, honored, and valued in order to develop self-esteem. Feeling extremely adored and loved will develop good self-esteem. If you can understand one's family of origin, you can see or not see love. With the antisocial's anger, he gets what he wants by manipulating, stealing, cheating, and deceit. If one does not care about himself, how can one care about anyone else? There is no effective treatment for antisocials. To manipulate, to charm is strong in both antisocials and narcissists. They read people well and they understand others. This is why oftentimes they're both charming. The classic antisocial includes the con man, the seducer, the smooth talker, and sexual predators. Antisocials are motivated by wanting to get even, and narcissists are motivated because they want to be adored. The antisocial's lack of remorse is not caring, and the narcissist's lack of remorse is because he deserves it. I'm going to move over to obsessive-compulsive personality disorder. How am I doing with time? Obsessive-compulsive personality disorder are usually men. Their core issue is an internal conflict with power and control. This person's focus is on time, dirt, and money. The OCPD is stingy in his spending habits, especially with his wife or partner. The OCPD is cheap, tightly wound, controlled, and restrained. This person is never a leader, but oftentimes second in charge. The OCPD has difficulty showing love, warmth, or affection, as well as consideration. They are very linear people. Common careers for OCPDs would include accountant, attorney, paralegal, and engineering. The OCPD pays bills on time, follows rules in life, and is very organized and oftentimes makes lists after lists. Most often the OCPD pairs up with a histrionic, because the histrionic is everything he's not, including lively, fun, and spontaneous. The OCPD does not trust easily. Oftentimes, an OCPD has a secret and private sexual life with underground S&M, where he releases himself by being dominated by a dominatrix. Or he may have an extensive porn DVD or video collection, and there's a lot of secrecy around this. The OCPD feels very shameful around these desires and secrets. The OCPD withholds affection and is fear-based because he's afraid of rejection, of being hurt. They are drawn to having multiple pets because these pets are safe to display their affection towards. OCPD fathers tend to give more affection to their daughters until she gets to the point and the age where she develops. Then he withdraws because it appears too sexual for him. He is disconnected to his wife and overindulgent to his daughter. Also, I might add, he's very overly critical of his wife. It's very typical for OCPD men to drink alcohol for less inhibition in meeting a mate. OCPDs want to know the therapist's credentials, degrees, what university or college he or she graduated from. How many of us can relate to this? Right away, when you get a lot of that, you know what you're dealing with. Yeah. OCPDs can be especially challenging to female therapists. During the first session, if the therapist comes across as intellectual, the OCPD will respect you for it. Once you join with an OCPD, you have them for life. And OCPD people are usually lean and physically fit. They put a lot of attention into how they look, and they want to stay lean and in shape. OCPD people are aware of problems with social and occupational functioning. They have a restricted ability to express warm and tender feelings. You oftentimes will not see them smile or laugh. They do not see the big picture. They just see details. They are perfectionistic. They are insistent that others submit to his way of doing things, controlling. He's extremely domineering with his wife or partner. Someone who's been married a long time, oftentimes OCPDs will pair up with either a histrionic or a dependent personality disorder, and if this person stays with them over time, the partner will eventually become depressed, especially if it's a dependent personality, because this person doesn't have the strength or the ego and courage to leave the relationship, so the person becomes depressed. OCPDs make many lists, like I said before. There's excessive devotion to work at the exclusion of pleasure. OCPDs are not fun people, and you will rarely see them laugh or smile. They have a very low tolerance for frustration. They blow up frequently. They manage their anxiety by abiding to every rule. And I don't know if I need to say this, but it happens to be the most difficult personality to be in a relationship with because of all these reasons. Life for the OCPD is defined by rules. An example of someone famous with OCPD was Abe Lincoln, the penny story. He was very stingy with his money. They tend to be very stingy with their mate, whoever they're married to. I'm going to move a little bit faster now because I'm starting to run out of time. OCPDs have a keen ability to maintain control and pride themselves on it. They are not prone to impulsive behavior. They have a really hard time making decisions. OCPD is egosyntonic. He behaves in ways that others find distressing and that he is not aware of. That's a huge part of understanding someone with OCPD. He tends to blame others for problems that are happening within a relationship, never can see his own part in it. The OCPDs are indecisive, and their indecisiveness is the byproduct of thinking of the consequences of making a decision that is not a good decision. OCPDs are stingy with giving compliments. They are overly critical and very judgmental people. They are stingy materially and tight financially. They have issues, again, with time, dirt, and money. Another example of this, a lot of people will say, well, what does that mean? And I'll say that my brother-in-law, who is soon to be my ex-brother-in-law, he would come to the family and we would order a pizza, and my brother would separate all the slices because he wanted it to cool off faster. And so my brother-in-law would just scream and say, don't touch these slices, you know. He didn't want any germs on the pizza. So again, issues with dirt, germs, issues with time. They're either very early or very late to everything. It's very frustrating to be in a relationship with an OCPD. They also have issues with money. Again, tending to be overly stingy with their mate. They tend to place huge emphasis on being on time or early, but oftentimes they end up being late, but they tend to blame whoever they're with for being late. There's much conflict around time. They must start on time. OCPDs are phobic of germs and everything is neat and organized. However, if you go into their garage, they can't seem to throw away worthless objects. So there's boxes stacked everywhere in the garage. The OCPD's indecisiveness destroys his ability to be organized. These people spend more time looking for lost lists rather than making a new list. They make terrible financial decisions. The OCPD plans out carefully what he will wear regarding clothes. He's very precise with this. He's very scheduled. He likes to have his titles known in terms of education, degrees, credentials. These people are formal and they want to hang out with other status people. They have no interest hanging out with people that are not status people. They are moralistic, judgmental, and conscientious. This disorder is absolutely not cool. It's the most difficult person, like I said, to be in an intimate relationship with. They don't have much fun. Let's see, let me just go through this really quickly. You know, even with sex, they're very restrained, very uncomfortable. They have a very odd way of approaching their wife or whoever it is they're going to have sex with. And it has to happen ritualistically, schedules, sex often. These people tend to be taskmasters, and they like to be a dictator to their wife or their partner. Okay, I guess we're running out of time right now, so let me just see if there's any absolute must here. Regarding relationships, in disordered relationships, you'll see power dynamics where one person holds all the power. In healthy relationships, the power gets shifted back and forth from one to the other. It is more equal. Here, some important decisions of the couple are made by one person, and other important decisions are made by the other. In working with couples, always look at how power is distributed in relationships. Okay, I'd like to open up the group now to questions and answers. We have about 5 minutes.
Hi, you referred to the male personality pyramid, and I'm just wondering if, I know, for example, borderline tends to be a diagnosis that women are more likely to get. With these that you've talked about today, is there a gender, a common gender theme, or?
With which one?
All of them.
Oh yes, definitely. Histrionic tends to be more women. Borderline tends to be more women. Dependent personality tends to be more women. In terms of men, it would be avoidant personality, obsessive-compulsive, narcissistic.
Do we know if that's because the presentation is actually more likely in those genders, or because those people are more likely to get that diagnosis?
It's a good question. I think it's possibly a combination of both. Any more questions?
Yeah, have they determined what age the cutoff is for an infant who doesn't get attention? There would definitely be more likely chance of being antisocial.
It's a great question. I'm not specifically clear about that, but usually the infant is, in terms of becoming antisocial personality disorder, the infant will have to endure more severe problems, most likely after age 1. Because if it's before that, the person oftentimes will turn out schizophrenic or even have more severe problems. When the time frame for neglect, severe neglect, is even earlier in their life.
I'm interested in the antisocial personality disorder, and if you were presented with such a patient, who is believing that there's nothing wrong with them, that the world is okay, and that their belief system is consistent with how they've been since a child, and they've come against their will because the system has forced them to, or their family, or some other advisors, and you're in charge of helping this patient. How do you go about initiating some small degree of change in this patient?
Oftentimes there's progress that can be made when they're part of a group of other antisocial personality disorders, because the group is encouraged and reinforced to hold each other accountable to their behaviors. And when it happens right there in the moment, it's hard to deny it. So confrontation within groups of other members that deal with similar personality disorder problems.
So your treatment of choice is group therapy?
It's often more effective than other therapies for that reason. Yeah.
I noticed quite a few of the traits of narcissism and personality sound a lot alike. And so what I wanted to ask you is, you have someone coming in for the first time to a session, and you're assessing them, and you're saying, well, you know, a lot of this is like OCD, a lot of this is like narcissism. So what would the bottom line be? Would the bottom line be the charm versus, you know, I'm going to get back at everything? Or what would you use as your deal breaker as if you had to decide what they were more?
That's a great question. Dr. Coburn?
I mean, what you see is that there's often a very strong component of OCD and narcissist. But they're at night that, you know, the narcissist really is about arranging. You know, it's about adoration. You know, it's about being not just the center of attention, but really calling the universe to support that. And OCD is not that at all. So there is a very strong, in fact, we talked about it many, many years. There should be a separate category, you know, like a subsection of narcissism that includes it.
Thank you.
Thanks, Dr. Coburn. One last question.